It's not coming in this system. Okay. My paper is on RETCAM-based photography screening for retinopathy of prematurity, initial experience from Kerala, a Cradle ROP initiative. There is no financial disclosures. ROP is a retinal vascular disorder of premature infants, and incidence varies between 38 to 51% in low birth weight infants in India. So all at-risk babies needs to be screened. Out of 26 million annual live births in India, around 2 million babies comes in this at-risk group. And in Kerala, the estimated number of ROP babies are 2,700 annually. The gold standard for diagnosis is binocular indirect ophthalmoscopy by an ophthalmologist, but the survival rates among neonates have improved, and there is paucity of ROP caregivers given this increased load for the analysis. The fundus imaging with RETCAM for ROP screening is followed worldwide currently, and there is paucity of data from India, especially NIL from Kerala. KidDrop, it's a non-physician RETCAM-based screening going on successfully in Karnataka for last 10 years. So aim of our study is to assess the initial experience of RETCAM-based digital screening for ROP in neonatology centers through the mobile Cradle ROP screening initiative. We checked the feasibility of digital screening, effectiveness, safety, and safety of non-physician-based ROP screening. It's a prospective study. We analyzed the data from 12 neonatology centers, and the infants meeting the ROP screening criteria by the National Neonatology Forum were included in the study. Cradle ROP team comprises of project manager, trained optometrist, trained ophthalmologist, ROP team nurse, and a crew. Our ROP screening was based on weekly schedule across the southern 4 districts of Kerala, and the average distance covered was 55 to 275 kilometers per day. We used RETCAM shuttle in the NICU step-down room for the screening after taking informed consent from the parent and under cardiorespiratory monitoring in the NICU. Pupillary dilatation attained by 2.5% phenylephrine and 0.5% cyclopentolate, and topical anesthesia using paracaine. We used sterile lid speculum for the adequate eye exposure. We used the images were taken by the trained person using RETCAM shuttle, and the goal was to attain 6 focused images with optic nerve centered, disc superior, disc inferior, macula centered, disc nasal, and the disc temporal. All the images taken in the neonatal ICU were transferred to the base hospital at Trivandrum for the ROP expert. We used international classification of ROP. Out of 422 screening sessions, initial 61 sessions were screened and diagnosed by trained ophthalmologists, and later 361 sessions screened and diagnosed by trained optometrists. All these sessions, double masked imaging and diagnosing by the ophthalmologist were also done, and these images were sent for teleconfirmation. And on validation, in the initial months, there was a mismatch between the optometrist diagnosis and the teleconfirmation, but later on, this mismatch was not there. Out of 184 babies screened, 25% babies developed ROP, and the postnatal age of first screening was 4.6 weeks, and mean number of screens per baby was 3.29. On analyzing the risk factors, there was statistically significant correlation between the incidence of ROP and the risk factors like birth weight, gestational age at birth, oxygen supplementation, invasive and non-invasive ventilation, and the respiratory distress syndrome. Out of 46 babies, 13 babies required laser treatment, and the incidence of ROP in very low birth weight baby was 57%, and in extremely low birth weight baby was 69.2%, and we detected the ROP even in 34 to 37 weeks gestational age babies. It was around 4.3%. 4 babies had threshold ROP, underwent laser treatment in both eyes, and 8 babies had pre-threshold ROP, also underwent laser treatment in both eyes. We had 1 baby with AP ROP. That baby underwent intravitreal anti-VEGF injections in both eyes, followed by laser treatment. 1 baby needed surgical management. In few of our sessions, diagnosis was difficult because of poor clarity of images. The reasons were highly pigmented fundus, poor dilatation, vitreous haze of extremely preterm, and small palpebral fissure, but the image quality was very good in 97.4%. 96% of our babies completed follow-up, and the attrition rate was low, that was around 4%. There was no serious complications in our study. We had 1 minor complication like localized retinal hemorrhage, which resolved by itself, and the apneic spells and bradycardic episodes were less. So coming to the advantages of digital screening, first the safety profile. It was less traumatizing to the preterm or extremely preterm babies, and the acceptability by the neonatologist and parents, decreased bradycardic episodes and apneic spells. Coverage of ROP screening per day is more, and the learning curve for REDCAM screening is less compared to the learning curve for an indirect ophthalmoscopy in the neonate. It's our present data. We have screened already 855 babies, and we have diagnosed 203 ROP babies, and 49 babies needed laser treatment and 4 babies needed intravitreal anti-VEGF injections. Our REDCAM data validated, and no treatable ROPs were missed. Limitation of our study, limited participation centers and all from private sector, and NICU treatment protocol were not standardized within the participating centers, and the difficulty in acquiring and interpretation of the images in some cases, and the REDCAM images were not compared with binocular indirect ophthalmoscopy in this initial analysis. So I conclude, REDCAM aided digital screening is feasible for early diagnosis of ROP in Kerala, and a non-physician based screening by trained optometrist within the NICU is feasible, resource friendly and safe. So this strategy ensures wide coverage of screening and has a very good acceptance rates among parents and neonatologists. Thank you.